Hello, everybody. I am Miriam Sabin. I'm the North American editor for The Lancet, based in New York. I'm really delighted that we can bring to you today this important discussion on public policy and health, in particular this time looking at reimagining care for Americans with severe mental illness. This is a topic that never gets enough attention, but is so important, especially looking at the magnitude of need in the United States. And I'm really glad that The Lancet could partner with all of our esteemed colleagues who are here today. Before we get started with the discussion, and that is me, Miriam, we can go into the housekeeping rules very quickly. So you have a quick overview of how this works, and then we will start the conversation. So just to let you know that attendees are welcome to submit questions throughout the presentation. Use the Ask a Question box on the dashboard. And on the webinar dashboard, you will see a box with related resources. A link to related Lancet content is featured and will take you to thelancet.com. You can adjust or minimize any of the boxes that appear on the webinar dashboard to suit your preferences. A link to the on-demand version of the webinar will be emailed to all of you who have registered once the event has concluded. And once the webinar has ended, please do complete our 30-second feedback survey so that we can continue to improve our webinar offerings. And with that, I would like to hand over the presentation to Nichole Roxas. I can't see your slide up there, Nichole, so apologies for that, but there we are. Nichole is a fellow with the Child and Adolescent Psychiatry, University of California, Los Angeles, and she will be our moderator for today. So Nichole, take it away.
Thank you, Miriam. And thank you all for joining us today during this Lancet Health Justice webinar series. As a child and adolescent psychiatry fellow at UCLA, it is obvious for me that humanity is reckoning with an escalating mental health crisis in the US and globally, with minoritized communities disproportionately impacted. Though access and investment in mental health care are often cited as the solution, it is sobering to reckon with data from the US, where the federal government spent $280 billion on mental health services in 2020 alone, and has more mental health resources per person than almost any other country. As a child psychiatrist in training, it is heartbreaking to witness how our children and youth are even more vulnerable given their development. Moreover, I just want to speak on the moral injury of seeing people who are unhoused, coming into the ER, suicidal, and then their SI fades because their basic needs for food or shelter get met, but then we discharge them back to the same structurally violent environmental forces like structural racism, xenophobia, and homophobia. These forces are weathering people down. And for people with severe mental illness, it cuts their lives short by up to 2 decades. The current system is failing. We need to do better, not only for our patients, but for ourselves, because our lives and our health are all connected. So it is truly an honor to introduce our esteemed panelists for this dialogue on reimagining mental health care for people with severe mental illness. First up is Dr. Sarah Vinson, a Harvard-trained physician, triple-boarded in adult, child, and forensic psychiatry. And among her many roles, she currently serves as chair of psychiatry at Morehouse School of Medicine. She will explore the current landscape of US mental health care from a structural racism and social justice lens. Then we have Keris Jän Myrick, co-founder and developer of Unapologetically Black Unicorns and board member of California Disability Rights. and she'll speak on her experience at the forefront of innovating and building peer-centered programs in the US. Finally, we have Dr. Roberto Mezzina, a physician and former director of the Trieste Mental Health System, current vice president of the World Federation for Mental Health, and chair of the International Mental Health Collaborating Network, who will discuss alternative care models for severe mental illness, including Trieste. Each panelist will have 12 minutes to speak, and I will try to kindly and firmly interrupt if needed to keep time and make sure everybody shares the mic so that we have about 15 minutes of Q&A at the end where I take your questions, dear audience members, that you input into the chat, as well as some of my own. And with that, I turn it over to the esteemed Dr. Vinson.
Thank you so much for that lovely introduction. I'm glad to join you all today to talk about this topic of public policy and health in the USA, reimagining care for Americans with severe mental illness. And I'm going to come at this from a social injustice standpoint, and I'll tell you why. Often when you hear people give talks, they give you their disclaimers, right? They tell you, I'm getting money from this pharmaceutical company, or I have this grant. And the idea is that by them doing that, you know how their views, how what they present to you may be shaped by their experiences or their different motivations. And my views and my experiences are shaped by being someone who has worked in community psychiatry, who has worked in forensic psychiatry, who has worked in private practice settings, but also who has navigated the world as a dark-skinned Black woman in a colorist, racist, sexist society, right? So these issues of injustice and how they shape how people think, how they feel, and how they behave, yes, it's an academic interest, but it's one that I could never separate myself from because it was such a part of my lived experience. I really appreciate the title of this webinar, right? Because we're talking about people with severe mental illness, but it says specifically reimagining care, not just reimagining healthcare. Because when we limit ourselves to healthcare, it doesn't allow us to go upstream, to think about social determinants of health. And we end up with this sick care mentality where we're focused on pathology, we're focused on what's wrong, and we're only intervening or allocating resources once there's a problem or someone is decompensating. And so I think with that in mind, it's helpful to go to a really basic definition. And it should be basic, but in some ways it's not. And that's the definition of mental health. And this is one from the World Health Organization that says a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to their community. And I welcome you to reflect on what is not in that definition and what it is that we often focus on when we're talking about mental health care or mental health care reform. There is nothing there about show rates in clinic or medication compliance or billing codes, right? There's nothing there about DSM criteria. This is about how people are operating in the world. This is about their connections to their community. This is about how they are able to realize their potential, to dream, and to pursue those dreams and have the resources to pursue those dreams. So much of that definition, dare I say most of it, has nothing to do with mental health care as we traditionally think about mental health care. So with this topic of reimagining care, we have to go outside of the healthcare realm, and we have to understand that it's not just you have schizophrenia or you don't, you have bipolar or you don't, because you can be someone who has bipolar disorder, who is realizing this definition of mental health, and you can be someone who doesn't have a diagnosis, who is not realizing this definition of mental health. So appreciating that everyone, irrespective of the diagnosis or not, can move up or down on this continuum between mental health and mental illness. And everyone is capable of moving up or down. And sometimes what I think we see in our policies and in the national discourse is this almost acceptance that there are people who can't get better or who won't get better or who are not a good investment of our resources as a society. And that way of thinking, right, perpetuates this cycle of disinvestment and then the poor outcomes that people then use to justify that disinvestment. So much of that definition too is going to be structurally mediated, right? It matters what educational system is in place. It matters what occupational supports are in place. And so there's mental health in all of these policies that shape these different social determinants of health. And we've gotten better about talking about social determinants of health, about thinking about them, but we've been doing that for a while now, right? We have decades of studies that show us kids not having adequate nutrition is bad for developing brains, that being unhoused is negative for your mental health, right? We don't really need more studies to tell us that. We know that, we have the evidence base there. The thing I think is interesting, though, is that despite the studies, despite the robust evidence base, and in a society like the US that actually has resources that they could deploy to really address these social determinants of health, we have chosen not to. We have allowed people to grow up in poverty. We have allowed people to be unhoused. We have allowed kids to be in educational systems that we know are not preparing them for college or for a career. And so that allocation of opportunities and resources in an inequitable way that reliably reproduces inequities and injustice is fundamentally an issue of social injustice. And our society is one where social injustice really does capture how we operate. So if we think about social justice, right, we're thinking about a fair balance in the distribution of wealth, opportunities, and privileges within a society where individuals' rights are recognized and protected. So in the absence of social justice, things that we know are bedrocks of mental well-being, like safety, security, and autonomy, are reliably and consistently going to be undermined. And often when we're thinking about trauma, we focus on things that happen interpersonally, or we think about things that are aberrations like car accidents or natural disasters. What we think of less, but what I would argue is just as powerful, if not even more so, is structural trauma. And that's the ways that our society's systems, our ever-present systems, our very powerful systems, contribute to people not feeling safe, contribute to families being ripped apart, contribute to people not having the basic necessities they need to attain that ideal of health. And as a result of that, one of the biggest indicators of how much we have failed is that in cities throughout the country, jails, prisons are the #1 prescribers of psychiatric medications. And how is that the case, right? So we have this really hierarchical social system, and we also have a very individualistic society in the US. And so our idea of America as this place where you have opportunity, where everyone can achieve, the flip side of that is that if you're on the lower end of that hierarchy, there must be something that you didn't do as an individual that placed you there. There must be something that's wrong with you or some decision that you didn't make that was correct that placed you there. So it's not our societal prerogative to help lift you up. And so our idea of America as this place where everyone can achieve is inconsistent with the idea that America is also a place that systematically makes it harder for certain populations to do so. And it justifies a lack of commitment to adequately funding the safety net and by extension to adequately funding the medical system. We're okay with this idea that you have to earn healthcare or you have to have a job that comes with benefits or things of that nature. And part of how we have that disconnect, right, is that there's a huge gap between the decision makers and the population, especially the population that has severe mental illness or the population that is at higher risk for severe mental illness because of psychosocial stressors. If we look at doctors, for example, the majority of physicians in the US come from families that are in the top quintile of US income. The majority of lawmakers are millionaires when you look at the federal level. And so the people making the decisions aren't closely associated with the day-to-day lives, the day-to-day struggles, the realities of the people they're making decisions about. And they're also not familiar with their strengths, with their potential, or often with their full humanity. And so what we see in the criminal justice system and that interaction with mental illness is that the criminal justice system ends up becoming the repository for all of our field policies. And a lot of times we talk about mass incarceration and we talk about it in terms of race, but if you look at it more broadly, what we have is the mass incarceration of marginalized groups. And that is whether they're marginalized by class, by race, by the presence of mental illness, or by the presence of a disability. And those groups are the ones that you really do see overrepresented. And so even when we think about how society is constructed and where we put our resources, if you were to call and try to get help for a mental health condition, if you're lucky, you're going to get a bed in 2 or 3 weeks. Depending on where you are in the US, you may have to travel hours to be able to get that kind of access. If you get in trouble and you need a jail cell, those are always available. They are always completely staffed, right? Well, not completely staffed, but they're always open for business, so to speak. There's places where we put our dollars, where we reimburse people for their skill sets, and places where we don't. You look at what a correctional officer is paid versus someone with a master's degree who's doing child welfare work, and it will tell you something about where we really prioritize things in our society. So in closing, when we think about this issue of policy and people with severe mental illness, I come back to this idea that there is mental health in all policy. And so part of our role is helping the decision makers understand that. This is not just about the mental health care system, because often by the time they get to our system, we're dealing with a tertiary care issue, but also as individuals, as people with some measure of power. And if you're on this webinar, you absolutely have some measure of power. How can you redistribute power and resources, whether that has to do with your platform or material resources that you have access to and control over? And I'll end with a quote by James Baldwin that says, "Ignorance allied with power is the most ferocious enemy justice can have." Medical training, psychiatric training, mental health training does not traditionally tell us about these things. So given the power that we have in our various roles, understanding these issues of social justice, understanding these issues of structural trauma are not a nice to have or a good to know, but they're essential to our role of first doing no harm.
Thank you so much, Dr. Vinson. Wow. And now we have Keris on breaking the chains of systemic oppression through lived experience-driven approaches.
Hi, thank you so much for having me on the webinar. It's been such an awesome privilege to be involved. And before I start talking about sort of the lived experience-driven approaches, I also want to contextualize where people with lived experience, such as myself, have been in trying to sort of break these chains of systemic oppression by understanding where the systemic oppression came from in the first place. So there's a Native American proverb that says, "Force, no matter how concealed, begets resistance." And so as we advance things in the United States, which is happening around using more carceral and coercion to support people with very complex needs who have severe mental health conditions, there's an advancement of more force. And so what's happening is, well, there's resistance. So that's actually kind of what's happening, which the Native American proverb says, well, that's natural. That's supposed to happen. You're not supposed to sit back and just accept it. But we also have to ask ourselves, what problem is coercion trying to solve? And I think this really also ties into what Dr. Vinson was speaking about, is that there are a whole host of social issues that are coming up that then the scapegoat becomes mental illness. But So why in the United States in particular, and particularly now, is there a focus on advancing coercion, such as courts, involuntary treatment, um, um, expanding what we call LPS in California, for example, which again is guardianship or involuntary treatment, hospital beds and the like. And so in the United States, of course, we've seen an increase in homelessness. We've seen increases in poverty. We don't have affordable housing. We've had the aftermath of the impacts of COVID, which is people losing their jobs. And of course, these overwhelmingly affected Black and Brown and Red communities. I'm a Black and Muskogee, I'm a member of the Muskogee Nation. So just being clear about even my own relationship to this issue. So there's a public perception with all of these problems that somehow this must be about mental illness. There are voters' concerns that say, hey, make our streets safer, and also the voters are saying, hey, make our streets safer and address all of these people who are out here in the streets. You need to do something about it. And they're doing this in an election year here in the United States. In California in particular, where I live, in Los Angeles, we're coming up on the Olympics. So look around the country and look around the world and see what happens generally during an Olympic year. Back in the 1800s in the United States, we had this thing called the ugly laws. And the ugly laws were a way to remove people who were maimed or disfigured or problematic or alcoholic, quote unquote, from the streets and put them in institutional care or somewhere where people couldn't see them. That was the 1800s. And the last one of those laws that was demolished actually wasn't until 1974. So it feels a little bit like we're going back to the ugly laws kind of feeling of, let's get rid of these things that we don't want to see in public by moving them away out of our vision. But, we've talked about a lot of complex things that are happening in people's lives. And complex issues rarely have simple answers. But it seems to be very simple to say, hey, coerce people, hey, make those people go into treatment, whether or not that treatment is effective for them, whether or not it's culturally or linguistically aligned, it doesn't matter. The goal is to get people in treatment and move them out of our way. And so what has happened has easily become that mental health has become the new scapegoat for societal issues. And rather than looking at the fundamental underlying societal issues that we have to address, which are complex. So it's not easy. It's easier to focus on the individual and blame the individual, and it's the medicalization of distress. I like to use this image of an elephant too to talk about whose story is being paid attention to. So there's a story about three blind men and the elephant, and each of them touch the elephant, and one says it's the ear and decides it's one thing, and one touches the trunk and says it's something else, and the third touches the leg and says, no, it's this. Each of them is touching a piece of the elephant, but say it is the elephant. And what we have happening in our advocacy world is families are having a particular experience. There's a lot of fear, there's a lot of concern, there's a lot of trauma. And when that happens, it turns into control. I'm scared, I'm afraid of my loved one, I'm really worried about a tragedy, and I'm frustrated with the system. So the pathos, the stories of the families have overridden the experience actually that is happening for the person with lived experience who is saying, hey, these systems aren't working for me. They don't meet me where I am. They don't provide the services and supports in the community where I need them. It's focused on the symptoms and symptom control versus focusing on the life and the life that I want to live. And if you have a serious mental health condition like schizophrenia, I do believe that there isn't a belief that you have a life worth living, or it's going to be a limited life, and somehow there's some control over how much you can actually achieve. Cohen and Cohen in the 70s did a study about what's called clinician's illusion, which is very much like something I'll talk about in a minute, but it is about having a belief about a particular population and having low expectations about that population. And that's kind of what's happening, I think, particularly for people with severe mental illness. But we have this issue that's a problem, and that's the problem of the single story. And right now we have a single story that is focused on people with severe mental health conditions who are unhoused, who need to be coerced. And that's the single story. But that's not the whole story. That's not everybody. And people don't even understand a lot of times what has happened, again, what we've talked about, that causes people to, I would say, I don't say they're cracks in the system, I say they're chasms, and people are falling through giant chasms in the system of care and other supportive systems that address some of the societal issues. So I talked a little bit about clinician's illusion, which is very similar to Pygmalion effect. So when receiving services, if there's low, and I'm a person who was diagnosed with schizophrenia, so I'll just explain it this way. I was actually told when I was first diagnosed, I would never go back to school. I would not complete my degree. I would not go back to work. I needed to take medication for the rest of my life, and I needed to live in some sort of custodial care with my parents or somewhere. And that's the way that I was treated. So that was the expectation for me. And for a while, I reached that expectation. And everybody said, oh, look, it's just like having schizophrenia. She's reaching that expectation. And my parents said, oh, no way. We have heard this story before, especially when we're raising you as a Black child in America. And they said, you can do whatever you want to do. And so there was no limit on my abilities, even when given a diagnosis of schizophrenia. And I did go back to school. I finished 3 degrees, ridiculous degrees. I don't know who needs 2 master's degrees. But anyway, I finished 3 different degrees. You know, I'm a vice president at a particular organization. I've been a CEO. So the sky has been the limit when there was no limit on the sky placed on me. This is happening day in and day out to people with schizophrenia. And they're reaching this expectation that is set before them. Oh, you're going to be homeless. We have to coerce you because you're homeless. Well, voila, we have people, you know, who have not had the services and supports provided as needed and end up unhoused for a variety of reasons. And then it said, oh, see, it's because they have schizophrenia. So I hope that makes kind of sense how this is a cycle that's very, very hard to break out of. The other thing that we have to deal with other than racism and other things is saneism, which is the discrimination and oppression against people who have or who are labeled or perceived as having a mental illness. So we don't use that terminology a lot. We may talk about ableism, racism, the other isms, but in psychiatric disability, I want to make sure that we understand what is saneism and the effects of saneism. So what we've been doing in the mental health movement is particularly with people with, I will say, psychiatric disabilities rather than saying severe mental illness, because when I say psychiatric disabilities, it puts us into a disability justice and rights framework, and we move beyond a disability and justice rights framework to disability justice, again, which may be a new term to people. They may have heard disability rights, they may have heard disability inclusion, but what is disability justice? So disability justice includes 10 principles, which really put disability at the center, and including psychiatric disabilities, of a whole host of issues relative to justice issues. So there's the intersectionality. I'm not just Black, I'm not just Native, I'm also female, I identify as non-binary, I'm a what's called a military Black nomad, or a military brat, or a global nomad. So I have all of these intersecting identities. So to separate out those identities is impossible and just support me in a way that just says, oh, you have a psychiatric disability. There's more to that person than just that one thing. That leadership must be led by those who are most impacted. So when we're trying to reform, reimagine, change, transform, leave, whatever we're doing with the mental health system, it has to be led by the people who are most impacted. Other things include anti-capitalist politic, commitment to cross-sectoral movement organizing around the coercion issue. This is the first time we have partnered with disability rights, housing justice, anti-police, those also other provider types who are like, no, we don't want to do this. This is moral injury. So how do we all work together? And then let me just get through this last part so you get this part. So, and you're not going to be able to see this, but this is about making sure that people with lived experience are involved in meaningful ways. At the top of the thing, this guy here wants to be involved, and they seem all excited about it, but basically they're telling him, no, we're going to give you tea and crumpets, and you better bring the same old people who will say yes and not say anything's the matter with anything. That will not actually cause system change. So we need to change that kind of paradigm by involving and using peer support, people with lived experience of mental health conditions, to provide support in community when, where, and how people need it, who look like the communities that are served, will really also make a difference. And there is evidence to the fact that they help people, be employed, reconnect to community, they meet people, their cultural needs, they reduce hospitalization, and a whole host of other amazing outcomes. Okay. And I'll end on this slide because the next speaker, this goes right to the next speaker. Oddly, I had no idea this order. But when I visited Trieste, one of the things when we tried to bring the program to Los Angeles County, nobody ever told me that Trieste was about freedom first. Nobody ever said it. So what were they looking at? I have no idea. But one of the beautiful things that peer support does and peer programs, peer respites, people with lived experience of mental health conditions is we rely on a freedom first, no coercion way of supporting people to be in community and to fulfill what they feel is their life calling and dream. That's what this is all about. Our dream is not to take medications and be in treatment all day long. Our dream is to lead a quality life that we have defined for ourselves. So thank you very much for your time and look forward to questions.
Wow, amazing. Thank you, Keris. And what a great segue to Dr. Roberto Mezzina, a whole system approach to a rights-based and open-door neighborhood service.
Pleasure to be here, and of course I'm an external observer, and of course I had some experience of visiting services, particularly in California and San Francisco, and more recently in Los Angeles, and also participating to what Keris mentioned before, so an effort to a great exchange between our experience and the experience of the Department of Los Angeles, mental health in Los Angeles, trying to set up a new effort to improve the quality of services and to address particularly the condition of people who are homeless, but not only trying to establish a system that is accessible and based on equity and based on rights. This is mostly based on our experience that Keris was so kind to mention before, but it's a long history because it started in the 60s when the movement started by people like Franco Basaglia. This year is 100th anniversary of his birth. So he was great pioneer, but with him, a group of people were criticizing, mostly psychiatrists, criticizing the conditions of people in the psychiatric hospitals in our country, and not only because this was about the same in the world. And so looking at the hospital, the asylum as like a container of misery, where people were socially excluded and also deprived of all their rights, so they became not anymore persons, but they became just the phantoms of an illness. And so that was because the psychiatric way of treating them, the psychiatric, let's say, ideology, particularly based on the medical model, was finding to a place where the people who are not can be when recovered in a medical sense, they should be put there, excluded, and lose everything, including the basic civil rights. So there was a movement to try to change this, and this started from closing the mental hospital as in the USA, but in a different way, I think. This should be underlined because this was based on setting up a completely alternative system in the community based on easy accessible community mental health services, particularly mental health centers, based in small neighborhoods where the citizen living in that area know the service, can access the services, a walking easily accessible facility, having universal access for anyone. And this was ensured by a reform that Basaglia and his group and other experiences across Italy were anticipating in psychiatry, and was echoed and scaled up in 1978 by the National Health Service reform that established a universal access to all healthcare, including mental health. And mental health was included in that. So this is the situation in our country, even if not all the premises of the reform were fulfilled, of course, but all the psychiatric institutions were closed after 20 years of hard struggle, that must be said, and some systems were considered, like the system in Trieste, as one of the best examples of good practice services, because they ensure a comprehensive response. In the title of my presentation, I talk about how I mentioned the whole system approach. This is mostly a definition that is not traditionally in the Italian history of the movement, but is taken from the UK, but reflecting on the whole person as the center of a support system where mental health services can contribute not just to clinical care, but to a wider and more holistic approach to all the life issues that the life challenges that we heard a person with mental health problems must face. So the services are anyway aimed at ensuring a coordinated effort to deliver a number of supports and interventions that can help persons' recovery, and more than that, people's emancipation from conditions sometimes based on dependency, based on misery, based on social injustice, and of course inequality, social inequality, even before then healthcare inequality. And we know how much mental health disparities are created socially. Of course, are based on the social determinants of health, and particularly conditions that people live. They affect more people with the lower position in the society. And so the effort is to ensure social justice through a service which is more fair and can ensure to anyone have the same opportunities to receive care, but not just treatment, a wider condition, a wider response to their condition, which is based on responding to whole life needs of this person. In order to do that, the only way we found is to create open access services, open door services. And if you come in our region, not just Trieste, but all the region northeast of Italy, Friuli, Venezia Giulia, all the services are keeping the door open to people coming in, and of course to those who are in the services to get out, including people in crisis, which are accommodated through a number of small community beds in the centers as complete alternative to hospital treatment, hospitalization. When the person is followed by the same team that knows this person, knows the needs, of course, it's a completely different condition, and it's much easier to try to respond, basing all the treatment on a relationship of trust, which is built with this person. So I think this is some of the basis of our experience. This is the work of Community Mental Health Center is complemented by, of course, supported accommodation rather than big residential facilities, as I've seen in most every country, including the US. In California, I've seen, but those kind of things mostly given to private providers. And the solutions for housing, for instance, they are included in solutions related to job placement, training, education for people. So the services are helping people to navigate toward a more true social and achieved social inclusion. Setting up social enterprises like social cooperatives, which are able to ensure training and placement. So because they are effective business-like, but they are inspired by social principles, so including people in their action. Of course, this is complemented by co-produced services with all the community organizations. So we think that every public service has a limitation, so they must work with the community resources and recognize and include community organizations, particularly those who represent people with mental health problems, their carers, and all the citizens which are interested in ensuring citizenship to people which are at risk of being socially excluded. So this effort is still ongoing, of course, and current conditions, particularly after the COVID, we know how they are hampering the possibility of a true social inclusion. But these are the inspiration and the values that we think must be overarching the action of community mental health services. We don't think that we must just deliver so-called evidence-based care, evidence-based intervention. We must ensure a response which is based on ethical principles and particularly on human rights, and must be centered on the person as a person. So this person must have a say, must contribute, must be an active element, an active subject in the process of care, and also in planning and delivering the services as a whole. So they are the first line of the community that must enter the services, must contaminate the services, must decide the policies together with the clinicians. So our effort is to keep this democratic approach open as much as possible, and to try to respect what is today considered by, for instance, by the World Health Organization, which represent the United Nations in the area of health, a rights-based and person-centered system of care. Human rights, which are declared by and other international conventions and covenants, must inspire care. People don't have to be ensured in terms of freedom, so freedom must come first. So freedom first, because we know that freedom is therapeutic. This is the motto we had that Keris mentioned, and I think this is a very important principle. Freedom must don't be deserved by those who are in a way compliant to care, but it's the premise of care, because it's the fundament of all the others human rights, the foundation of all the other human rights. I think these are the challenges today. These are reinforced by WHO and by other international organizations, and these are reflected in some of the best practices across the world. I hope that the effort in USA, which are going in this direction, will be supported by these principles. Thank you.
Wow. Thank you so much to all of our panelists. I'd like to invite them all back into the Zoom or the webinar platform for us to continue the dialogue. Just a few notes that I was hearing that so beautifully weave together your perspectives. This idea that all of you introduced yourselves as people, and instead of highlighting evidence, really highlighting the ethical principles and the basic human rights. And I think that has been key to recognizing also what we're talking about is we all have power, and how do we honor the challenge that Dr. Vinson, that Keris, that Dr. Mezzina lift up to us? How do we redistribute that power and share it, and put people with lived experience, peers, at the forefront? My first question is related to these values that we have, like justice and freedom first. How can we navigate practicing and building those systems of care if our socio-political landscapes, including our policies and laws, continue to be carceral and coercive? And this is a question for all of the panelists. And we invite you, audience members, please drop your questions into the chat.
If I should take a stab or not, but I'll take a bit of a stab. I think there are a couple of things. I think the way in which we are funded is a biomedical model that does not, again, sort of align with, even what World Health Organization says is health. So I always worry about, especially, when peers get into the biomedical model business, which we are as certified peer specialists, how can you do some of the things that you're talking about? So I think there are a couple of things. One is, I think that, we need to tie in funding for health-related social needs. And we also need to pay for performance, but not performance of compliance, not performance of I took my meds, I'm staying in treatment compliance, but rather, are there ways for people with lived experience, along with family members and providers, to come up with outcomes that really matter to the person, that are people-centered and driven. And that's what we're looking for our health systems, and that's what they get paid for. They don't get paid because they billed the hour, they get paid because the outcome was achieved. I think, and there is pay for performance, but what we have to define what that performance is. And right now, other people are defining that performance, we're not. I also think that there's still some things that fall way outside of even mental health. Mental health cannot take on the brunt of fixing all of the social problems. So I think, we need political will to say that the rising housing costs are out of control. Who owns all these housing, and how are the people who are driving these costs up paying into building affordable housing for people who need, especially people with behavioral health conditions in communities that they live? They're kind of off the hook. So they get to rake in the money, and they get to hold on to the housing, because we have more livable, available units in Los Angeles County than we do people who are unhoused. So that is not a housing problem, that is a greed problem, and that's what we need to work on.
Thank you. Dr. Vinson, Dr. Mezzina, anything you'd like to add?
Sure. So, I think this is a question that really is one for every individual. And I don't say that as a cop-out, right? But getting back to that idea of power and how you navigate practicing and building in systems, if you're a fellow like Dr. Rojas, right, what your power looks like is different than if you're a chair or if you're a medical director, right? And so what it looks like to be part of addressing these issues is going to change depending on the role that you have. And I say it that way because sometimes when you're looking at problems that are so big, it can become overwhelming. And you think, well, I can't fix the housing crisis, right? But what is it that you can do in your clinic that shows awareness, sensitivity, and responsivity to the fact that this is something that the people that you work with are dealing with? Does that look like partnering with advocates? Does that look like having housing resources available? Does it look like having a care coordinator? And that's not an overall fix by any means, right? But it is operating with a certain awareness that there are things that you take for granted, that your decision makers take for granted, that the people that you say that you're trying to serve cannot. And so there's the piece of what we do in the system, right? And then there's the part where we step outside of our system and step outside of our comfort zone and start trying to have conversations with the people who are making these decisions about things like housing policies that allow for not just affordable housing, but low income housing as well. Where we start having conversations, as they're starting to do with some groups in California, about what would it look like if a diagnosis wasn't required to qualify for services, right? What if you didn't have to be pathologized, but if you were a child in a family that was clearly in distress, and that was enough for us to start wrapping your family around with more support. And not all of us are in the position to do that, right? But thinking about where your gifts are, where your power is, where your ability is, and how you can leverage that.
Well, I think it's a very difficult matter. This is the challenge across the world. I think that one of the small responses was, of course, dismantle the most terrible kind of violations of human rights and justice, which were the old style institution. But it's not so different if you look at what is around today in terms of secure beds and locked places and many forms of institutionalization where people are in a way losing their rights. So I think that's one very important step, which is still undervalued, because while we have to fight for the implementation of human rights practices and policies with the inclusion and with the protagonism in the first line of people with lived experience and the carers, at the same time we should fight for changing the old style of delivering services, so the institutions can't be anymore considered to be a response to people, but just to issues of controlling their behavior, of the deviant behavior, so-called, in the society, so reproducing forms of inequality and exclusion. So that's a very important thing. So change institutions, create different forms of services which are must be made up of the participation. So the presence and of people with lived experience, the community. So engaging the community in a meaningful way, recognizing the importance of the community resources in delivering also the responses to the social needs of people, and the representation of the community organization within mental health care, community mental health care. This maybe can be some of the instruments that can allow to achieve a more humane and more equal system of care.
I really appreciate all of your perspectives and wisdom here. And I definitely wanted to lift up this question from an audience member who asks, how can you make these ethical arguments in the political sphere, recognizing that there is a high level of greed and self-interest, as previously stated in US politics?
Well, I think sometimes that's not the argument to make necessarily, right? In some environments, the ethical argument isn't going to get you very far. And so you start looking for other ones, like fiscal arguments that may translate better depending on where you are. And what we've seen in some of the conservative states in the US, right, is that just looking at how much money is being spent on things like competency restoration and putting people in jail and in hospitals just to have them cycle back in and out has been really compelling, in a way that saying this is not right was not for some of these decision makers, right? And so there's something to be said for knowing your audience and knowing what their values are, and understanding that though the ethical argument may move you, it may not move your audience.
Couldn't agree more. And also why sometimes people have a hard time understanding how I do my advocacy work as a person with lived experience, because the thought is that I'm going to lead with a value set, with a sort of morality set, like, no forced treatment. Well, of course I'm not a fan of forced treatment, but the powers that be don't really care about that. I mean, they may somewhere, but they're not going to say that out loud as legislators or policymakers. So I have to go where, if it's about data, I have to have the data to talk about the data and show where maybe disparities are, or where there are other issues that are important to that particular policymaker or legislator, or go for that fiscal argument, or go for that, what is it going to do to the youth argument, again, using data or something that is sort of, as Dr. Vinson was saying, in that person's, I would say, eyesight about what they're going to care about, and start to listen a little bit differently. Sometimes that has worked, and I'll be honest, sometimes it hasn't. I mean, we have a Black California reparations bill in California, and when the CARE Act was passed, as well as our advancement of conservatorship, SB 43, advancing LPS conservatorship, et cetera, I was using the state's data to show how this was disproportionately impacting Black Californians, among others. But because we had the Black California Reparations Act and bill that was passed and signed by the governor that says, you shall not pass any more policies or legislation that perpetuate disparities, they did it anyway. Mm-hmm. So sometimes even logic kind of giving the legislators back their very own things it didn't work, which was sort of surprising to me, but there were more compelling things that were on the state's table relative to the Olympics, relative to, possibly the governor running for president, the political things that really can also is really the driver. What may not be the driver is the thing that we're trying to solve, which is these very complex needs for people. It may not be about the people at the moment in that way. And I hate to say that feels kind of horrible, but I think that's something that we have to recognize and then be able to come up with strategies to address.
Yeah, that's very real. And Dr. Mezzina, you said it took 20 years?
Yeah, well, it's very difficult for me to comment about the American situation that I don't know so much. But what I've seen is that the basic point is that it's hardly to be seen a system in place. So there are many kind of programs going around. These are targeted to population. People cannot access in a fluid way all the kind of responses which are required. So I think it's very important to try to fight for having at least a community-driven system of care. That's the basic for me. And then, of course, this doesn't resolve the issues related to power, to political decisions, to social inclusion, but it's a start. And for instance, in our experience of the personal budget system that we set up in the last 15, 20 years, these are addressing the social determinants for people, particularly with complex needs, adding something more to the action of the standard, let's say, services, even working rather well in the community. And looking at these kind of instruments ensure the participation to the planning and to the delivery of these individualized personal budgets according to individual plans. And the way you do it, the way you include people, ensure a kind of democracy in healthcare. That is what we need, I think, everywhere in the world. So decision maker couldn't be left alone, and we must try to empower people, fight for empowering people through a participatory kind of approach. But we need a system.
Thank you all. And I want to be respectful of everyone's time. Any closing remarks or final takeaways you all wanted to lift up for the audience? I think I was taking a lot of notes. There was so much wisdom, and I really appreciate everybody sharing. Basically, I'm hearing so much about mental health in all policy, that we need to look beyond like the treatment plan, but to people's dreams and their hopes for like a life that's worthy of our breath, that we be rooted in ethical principles and also strategic in thinking about who on the other side with power and resources, how we can, invite them into this cause that all of us care deeply about and are all invested in as people. And I just want to say a very big thank you to all of our audience members who are joining us. This concludes our Lancet Health Justice webinar series, and just really appreciating the panelists again and the audience members for engaging in these reflections and dialogue. I hope that they inform and help us to shape change in our communities towards a more just, loving, and kind world. And I really appreciate everybody for their time. Thank you so much.
Thank you. Thanks a lot.